Hello everyone, myself Dr. Ekta, and today we are going to study Sjogren syndrome. Sjogren syndrome is a chronic disease characterized by dry eye or keratoconjunctivitis sicca and dry mouth resulting from immunologically mediated destruction of the lacrimal and salivary glands. It can occur as in primary form known as sicca syndrome or in association with another autoimmune diseases, that is secondary form. The associated disorders are rheumatoid arthritis, it is most common, then SLE, polymyositis, scleroderma, vasculitis, mixed connective tissue disease, and thyroiditis. Now coming to etiopathogenesis of disease, the disease is characteristic. There is characteristic decrease in tears and saliva, that is Zika syndrome, and it results from the lymphocytic infiltration and then fibrosis of the lacrimal and salivary glands. The infiltrate contains predominantly activated CD4 helper T cells and few B cells, including the plasma cells. 70% of the patients, they have rheumatoid factor and antibodies reactive with self IgG, whether or not coexisting rheumatoid arthritis is present. So 75% of patients will have rheumatoid factor. Antinuclear antibodies, they are detected in 50 to 80% of the patients. Antibodies directed against ribonucleoprotein antigens, that are SSA and SSB. SSA is RO and SSB is LA, that can be detected in 90% of the patients of Sjogren syndromes, and these antibodies SSA and SSB or RO and LA, they are serological markers of this disease. Patients with higher titers of antibodies to SSA, as if SSA is higher, then they have more chances of having early onset of disease, longer disease duration, and extraglandular manifestations like cutaneous vasculitis and nephritis. Most commonly occur in women between ages of 50 and 60. The keratoconjunctivitis, it produces blurring of vision, burning sensation in the eye, itching, and thick secretions that accumulate in the conjunctival sac. Another symptom is xerostomia. Xerostomia will result in difficulty in swallowing solid foods, decreased inability to taste, cracks and fissures in the mouth, dryness of buccal mucosa. In addition to keratoconjunctivitis and xerostomia, the patient may have parotid gland enlargement. It is seen in half of the patients. There is dryness of the nasal mucosa and epistaxis. Lung may be involved with the recurrent bronchitis and pneumonitis. And the extraglandular manifestations, they are present in 1/3 of the patients, and they are synovitis, diffuse pulmonary fibrosis, and peripheral neuropathy. This is all about Sjogren syndrome. Now we are going to take next autoimmune disease, that is systemic sclerosis or scleroderma. Systemic sclerosis is a chronic disease which is characterized by chronic inflammation due to autoimmunity, damage to small blood vessels, widespread damage small blood vessels, and progressive interstitial and perivascular fibrosis in the skin and multiple organs. So it is characterized by chronic inflammations, then damage to blood vessels, and progressive fibrosis, interstitial as well as perivascular fibrosis in the skin and multiple organs. Scleroderma is of two types, diffuse and limited. In diffuse scleroderma, it is characterized by widespread skin involvement at the onset of disease with rapid progression and early visceral involvement. Limited scleroderma, in which the skin involvement is often confined to fingers, forearms, and face. So it is known as limited. While in diffuse, skin involvement is widespread. Some patients with limited disease, they also develop combination of CREST syndrome, which is calcinosis, Raynaud's phenomenon, esophageal dysmotility, sclerodactyly, and telangiectasia. So the mechanism leading to systemic sclerosis, the exogenous agents, it will lead to injury of the blood vessels that will cause ischemia and fibroblast proliferations. The exogenous agents, they may activate the immune system, T cell activation, that will further release the cytokines and growth factors that will add to fibroblast proliferations, leading to extracellular matrix deposition and fibrosis. All organs can be involved in systemic sclerosis, but the prominent changes occur in skin, alimentary tract, musculoskeletal system, and kidney. Lesions also are often present in blood vessels, heart, lungs, peripheral nerves. So, when skin is involved, the patient have diffuse sclerotic atrophy of the skin, which usually begins in fingers and distal region of the upper extremities and extend proximally to involve the upper arm, shoulder, neck, and face. Histologically, there is edema and perivascular infiltrate, then swelling and degeneration of the collagen fiber, and thickening of the basal lamina, endothelial cell damage, and partial occlusion of the capillaries and small arteries. With the progression of disease, there is increasing fibrosis of the dermis and marked increase of compact collagen in the dermis, thinning of epidermis, loss of rete and atrophy of the dermal appendages. There is hyaline thickening of the walls of dermal arterioles and capillary. So in this microphotograph, you are seeing there is extensive deposition of collagen in the dermis and absence of appendages with foci of chronic inflammatory infiltrate. In advanced systemic sclerosis, the extensive subcutaneous fibrosis will lead to immobilizing fingers, causing claw-like flexion deformity. You are seeing claw-like flexion deformities, and there is loss of blood supply which will lead to ulceration. Alimentary tract is affected in 90% of the patients. There is progressive atrophy and collagenous fibrous displacement of the muscularis. So muscle is replaced by collagenous fibrous tissue. It may occur at any level of the gut, but most commonly and severely affected is esophagus. When the lower third of the esophagus is affected, they develop rubber hose inflexibility. Associated dysfunction of lower esophageal sphincter will give rise to gastroesophageal reflux and its complications like Barrett esophagus, Barrett metaplasia, and strictures. The mucosa is thinned out and may ulcerate, and there is excessive collagenization of the lamina propria and submucosa. In the small bowel, there is loss of villi and microvilli, leading to malabsorption syndrome. So, in alimentary tract, the muscle is replaced by the collagenous fibrous tissue, and esophagus is most severely affected, leading to inflexibility, Barrett esophagus, strictures, and mucosa is ulcerated, and extensive ulceration in lamina propria and submucosa. There is loss of villi and microvilli in small bowel. In musculoskeletal system, there is inflammation of the synovium associated with hypertrophy and hyperplasia of the synovial soft tissue in early stages, and in later stages there is extensive fibrosis. Renal abnormalities, they occur in two-thirds of the patients with systemic sclerosis, and the most prominent is vascular lesions. So vessels are involved. Interlobular arteries, they show intimal thickening as a result of deposition of mucinous or finely collagenous material. There is concentric proliferation of intimal cells. These changes may resemble those seen in malignant hypertension, but in scleroderma, alterations is restricted to vessels with 150 to 5000 micrometer in diameter and are not always associated with hypertension. But hypertension may occur in 30% of the patients with scleroderma, in which vascular alterations are more pronounced, that are associated with fibrinoid necrosis involving the arterioles together with thrombosis and infarction. There are no specific glomerular changes in scleroderma. Lungs are involved in more than 50% of the individuals, and involvement manifests as pulmonary hypertension and interstitial fibrosis. When heart is involved, then the diseases are pericarditis with effusion, myocardial fibrosis, and thickening of the intramyocardial arterioles. Clinical myocardial involvement is less common. Thank you.